CME. The International Retromacular Traction Study Group, they showed it is probably a defect in the inner fovea with irregular contour, intraretinal splitting, and mostly intact photoreceptor layer. The pathogenesis primarily is because related to the PVD, and secondary because of this unroofed CME, end-stage ARMD, MACTIL type 2, solar retinopathy, tamoxifen retinopathy, as well as partial closure of the full thickness macular hole. A few definitions are important before we go into this lamellar hole epiretinal proliferation. Excuse me, can I have a point? So epiretinal membrane, as we all know, it's an irregular and hyperreflective layer over the ILM with signs of wrinkling of the underlying retina and hyperreflective spaces between the ARM and the ILM, where the epiretinal proliferation is a thick, homogeneous and isoreflective, fully adherent layer over ILM with no hyperreflective spaces between the membrane and the ILM. The third one is the ARM foveoschisis. These are the level of the Henle's layer, where we have microcystoid spaces in the inner nuclear layer. Retinal thickening is there and there is wrinkling. And the fourth one is the macular pseudo hole, where you have a foveal sparing, center sparing ARM, verticalized or stiffened foveal profile and normal central foveal thickness. So this is one which is a typical epiretinal membrane, where you have a membrane. There are some space in between the retina and the membrane compared to the epiretinal proliferation, where you don't have much gap in between the membrane and the ILM. So these are the two definitions which is being studied extensively. There are different nomenclature on that. So the first group is the ERM, the tractional ERM component, where you have irregular hyperreflective layer attached to intermittently to the retina, compared to the thick homogeneous material. We call it either thick ERM, dense ERM, or thicker ERM, or LHEP, where you have a thick homogeneous material of medium reflectivity, universally adherent to the retina, and there is no traction. So definitely we have a different approach to this. The first component is tractional lamellar macular hole, where we have a typical ERM, and the degenerative lamellar macular hole, where you have some photoreceptor abnormality. Also, if you see in the lower picture, we have a degenerative lamellar macular hole, where there is a presence of adherent epiretinal proliferation. It's very difficult to distinguish the membrane from the ILM. So the epiretinal proliferation is a hallmark of this LHEP, where you have seen it is actually derived from the molar cells. We have RP proliferation and migration through the defects. Usually they have a lower visual acuity because of the photoreceptor disruption, and rarely there is traction. And if you see this picture, yellowish hue seen intraoperatively is derived from the carotenoids, and epiretinal proliferation was present in 26% eyes in patients who actually had a full thickness macular hole surgery. So when to plan surgeries in LHEP, where you have already disturbed vision, there are certain indications on that. We have a prominent ERM, less symptomatic, but patient is having mild distortion. 60% of these patients are associated with thick membrane and CME with a significant distortion. These are indicative. Surgery who have progressive disabling visual loss and increased in ellipsoid zone disruption, they also fall into this category. And in patients who have a less than 20/40 vision with evidence of ERM, only thing we have to keep in mind is these studies also have told that cataract can be a confounding factor in these patients where there was visual gain after the surgery. So LHEP progression also, if you see this patient who has been operated, there was a lamellar LHEP with a lamellar hole, epiretinal proliferation, progressed to a full thickness macular hole. Even after surgery, you have a small neurosensory defect. So in proportion of eyes which had has a anatomical progression was 13 to 21% after 2 years of follow-up, going up to 33% after 8.3 years. The surgical technique is usually a standard 3-port vitrectomy with IVT assisted PVD induction. A diamond-dusted silicon tip or bent 25 gauge MVR is used to engage the LHEP tip at the periphery after staining. Sticky LHEP peeling started by engaging the ILM forceps, which is not occupied by ERM, is an easier technique to tackle this membrane. There are a few propositions about embedding the LHEP into the retinal cleavage with very good surgical outcome. And Mores Calci, they also advocated leaving the intact ILM, so around 2 Ds diameter, or the foveal sparing technique for these conditions. There are a few people who proposed not to have a trimming of LHEP, probably advocated trimming of LHEP around the whole margin with scissors and keeping a flap over the LMH. These are different techniques which is being published. This is one from the Disha group, where they had also had a modified surgical technique of embedding the flap. So this is the membrane embedding technique, where the first one we can see the ILM is being actually started, then followed by the ERM, which is being both embedded over the lamellar macular hole. So this one patient who had actually had a flat membrane, we can see we do a vitrectomy and PVD induction, followed by staining, brilliant blue staining. You can see here negative LHEP staining here because of the membrane, and you start removing the membrane first around the ILM flap, so that you can actually get into the membrane. You make a flap of the ARM over this. Few things you have to keep in mind, because there are a lot of appendages here, so you have to be very careful while you start removing the membrane. The first flap is the epiretinal flap, which you keep around the fovea. After that, you start you may do a staining again. So multiple times staining is important for this type of surgeries, where you can actually have different layers coming together. Now you can see a very good stained ILM. Now you start making the ILM flap. So you don't deroof the ERM, and you don't deroof the ILM also. So you just do what you actually do in inverse flap. You make a flap, ILM flap, circumferential ILM flap, and you, once it is freed from the peripheral ILM, you embed it over the lamellar macular hole, and then you circumferentially further peel the ILM, as we are normally do in any other macular hole surgeries, to remove the peripheral traction. You are trimming the peripheral ILM. These patients need a full FG and full gas. This is by your soft tip, you can just embed the ERM ILM flap over the LMH. Full gas, and these are the comparisons where you see LMH without LHEP with maintained ellipsoid zone, post vitrectomy, where UR removal and ILM peeling is there. This patient, even you can see here, there is no photoreceptor defect. This is a typical tractional ERM, compared to this right side, where you can see a lamellar hole epiretinal proliferation, significant photoreceptor innoretinal defect, photoreceptor defects here. And even after 1 year of following surgery, the visual acuity was not significantly improved compared to a normal ERM. So the surgical difficulties what we face in this LMH with LHEP with altered ellipsoid zone. These are the yellow arrows with dotted lines where we can see the LHEP. So the first one is it's elastic and friable, which is difficult to peel. LHEP peeling for degenerative LMH can lead to macular thinning and even full thickness macular hole. And dense epiretinal proliferation have a yellow, dense, fluffy appearance. Sometimes it becomes very difficult to distinguish while removal. These are a few meta-analysis. This is a meta-analysis about the comparison of surgeries where they have done without LHEP and with LHEP epiretinal membrane. And this was the apparent surgical outcome. So BCVA recovery in LHEP patients was less compared to the patients without LHEP. So this has to be very kept in mind. LHEP might be a part of the recovery process of a LMH. Double inverted ERM as well as ILM can preserve LHEP and promote LMH recovery. Despite low visual acuity, thinner CFT and disrupted ellipsoid zone, 50 to 79% patients of LHEP had a normal foveal contour restored, which was reported in around 19 papers. So that is one thing which probably is a positive outcome from this surgery. Eyes with LMH and LHEP, where we have seen a reduction of the IOSOS defects in patients with LHEP, which was more compared to patients without LHEP, because photoreceptor abnormality was less in the second group. So to conclude, most of the LMH proliferation with minimal visual complaints can be observed. Though LMH, LHEP carries a poor prognosis, surgery is advocated if there is increasing metamorphopsia and decreasing vision. Pre-op OCT biomarkers are helpful to counsel a patient in LHEP, because they sometimes can have not suboptimal visual acuity recovery, and they need a very serial follow-up too. Newer modifications in surgery of LHEP are showing promising anatomical and functional results. So thank you so much for your patient hearing. So I would request audience, if you have any questions regarding this specific talk, or otherwise I'll call the second speaker. I request Dr. Aniruddha Maite. So Dr. Maiti will be having talk on myopic, on macular hole surgery in different situations. We have few reshuffling of these talks because of concomitant ICs in other rooms. Dr. Aniruddha Maiti, please.
So how is this visual acuity? You have shown this meta-analysis as well. So what is your experience of this LHEP with ARM?
I feel that most of the time if the patient is symptomatic, they have definitely has improved, but the visual acuity improvement, what we get in normal typical ERM surgery was not that great. But patients were symptomatically better. Distortions, metamorphopsia was not that much. But what we usually get in conventional normal ERM surgeries.
So this is more helpful for those who are symptomatic patients.
But photoreceptor abnormality was much less compared to what pre-operatively, post-operatively.
Non-surgical.
It was normal. It was not normalized.